Welcome, Dr. Jyoti Budi. I congratulate you. You are charisma by seeing the crowd and the delegates here. She's very down-to-earth person, helpful, very helpful, warm and affectionate. Thank you for the opportunity. And to 49 fertility centers and 7 centers across Telangana and Andhra Pradesh, ISAR Telangana Joint Secretary, ISAR Scientific Committee 2020, MS in Reproductive Medicine UK, FS Certified Clinical Embryologist, chapter contribution to several books, invited guest lecture at international and national conferences, presented many papers at national and international conferences, Times Best Fertility Clinic in South India 2021, emerging, Times Excellency Award 2018, the Best Fertility Clinic in 2018, HMTV Best Health Services Company Jury Award, BEA 2018, Indian Excellence Award 2017, National Healthcare Excellence Award 2016. I welcome you, Dr. Jyoti.
Thank you so much. At the onset, I would like to thank all the delegates here. I'm so overwhelmed today. Thank you so much. Amidst the Sunday busy schedule, you're all here. So we value your time, and we have wonderful national speakers who have come all the way here. So I will not take 30 minutes. I'll try to wind up in 20 minutes and give time for our national speakers to move ahead. So they say it takes 8 years to be a gynecologist, but to be the best version of our own self, it takes lifetime. In this space of making of our own self, there are lots of mentors, seniors, many teachers here who I have a lot of respect. It may be our parents. So with a big salute to them, with a bowing hand, I start my presentation. I'm talking about initiation of IUI with ovulation induction and folliculometry. So we'll start with a real-time case scenario, which happens day to day in our practice. Just to make a more connected, I've chosen an arbitrary name, Sagar and Shilpa. These loving couples have, she is 32 and Sagar is 36 years. They're married for 10 long years. And they're very anxious to have a baby since 7 long years. Everything is fine in this couple. Husband's sperm parameter is perfect. Her tubes are patent, but only problem what this Shilpa has is she has irregular cycles. Once in 3 to 4 months she has cycle. So this is the most common scenario what we see in our in a gynec OPD. So every time I feel patients are our best teachers. Whenever we see a patient, we learn a lot from them. So from her, I learned 2 important things. What are those things? What I learned was, first thing was, why did it take 7 long years for Shilpa to conceive? Only problem she has is irregular cycles. Then I was wondering what went wrong. I just went 2 pages and I started seeing her case notes, what happened for the 7 long years. Again, end of the day, when we talk about folliculography or folliculometry, physiology plays a very pivotal role. So after a beautiful talk by Dr. Shravya, which was, challenging cases, I'm taking into physiology, little subtle subject, but without understanding physiology, we can't be good in ovulation induction. So it's so important to understand little basics about physiology. So whenever I think about physiology, I have fallen in love with this subject. Because it's so important what happens in the ovary day-to-day basis. It is something very, I call it as a story of scientific romance. So what actually from the patient, what does patient want? From patient perspective, they want fast success rate with less side effects. This is what they want. So from Shilpa's case, what I learned 2 things was, whenever a lady comes with irregular cycles, say suppose she has come to me on day 2, we start her ovulation induction medication. We'll call her usually on 7th or 8th day. Then we do a scan. When we do a scan, what do we want to see? We all like to see a selected follicle. A follicle, at least it is around 12 mm. But if at all, if there is no follicle on 7th or 8th day, if all the follicles are less than 10 mm, what do we do? Okay, there is no dominant follicle for you, you come again next cycle. Now in case like Shilpa, If we don't give a withdrawal flow, when will she come back to us? She'll come after 4 months. So we are losing 4 months, 4 precious months in her. So we as clinicians should be able to find the threshold dose for that woman. And also there is something called as window period, very, very important. These two small concepts, I won't bore you. I'll try to, in 5 minutes, finish this concept, which is very important. So from times immemorial, from decades, 20 decades, everybody knows the study in 1996, Tomilson et al. To today, everybody knows to increase the clinical pregnancy rates. With 1 follicle, it is 8.5 pregnancy chances. When it's 2 follicle, the success rate doubles. 3, they say triples, but I don't suggest 3. We have to plan for 2 follicles, but for whom I will be telling you in later slides. Of course, after 3, it doesn't increase at all. So 2 is the ideal number. So every house has a window. Even ovaries have their own window. And the window doesn't open every time, whenever we want. So why do we all know then we stimulate the ovary on day 2, 3 or 4 or 5. Why do we do it? When a lady comes to us on 14th day, okay, she has come, she doesn't have time, shall I stimulate her ovary? Have we ever done that? We don't do it. Why is it? It's because if you see physiology, the window of the ovary is open only at that point of time. What is that point of time? It is the menstruation. See, there is an ovarian cycle, there is a uterine cycle. Creation of God is so nice. Whatever is happening in the ovary, it is not seen until we do scan. But in physical way, the endometrium sheds and we can see its menstruation. So window period, whatever happens in the ovary synchronizes with the uterus. So that is the time, a menstruation, what we call. So if you see this slide, a lady with a normal reserve, window period is during menstruation. A lady with PCOS, she has a prolonged window period. That's the reason even in PCOS, we can start the stimulation little later. In women who has very less reserves, 1 or 2 follicles, window period is shortened. What is this window period shortened? You see on a day 2, if you do a follicular study on a lady with less reserve, you already see one of the follicle dominant. That means to say HPO axis is starting faster. And already on day 2, it is a 14 mm follicle. Most of the time we see what is this. That is the first time when we catch a lady that, oh, this lady is, ovarian age is advancing. If it is more than 10 mm, ideally for a normal responder, on day 2, the follicles should all be quite less than 10 mm. But if a lady with 2-3 follicles and 1 follicle is already dominant, 12 to 14 mm, then her window is shortened. She comes, usually if you see her history, she comes with shorter cycles. From 30, it has become 24, 25, 15. That means luteal phase is fixed, but her follicular phase is shortened. And these ladies, 7th or 8th day itself, they ovulate. So it's a challenge for us. And what happens in folliculometry? If you see the follicles there on day 2, we would always like to see a follicle which is very quiet, no activity at all, resting phase of the follicle. Each follicle is less than 10 mm. And then you don't like to see a dominant follicle on day 2, right? If you see the endometrium also, endometrium will not be triple line, it will be shedding. It will be less than 3 to 4 mm. That is what we see in a uterus. Then ideally on day 2, if you have to combine the ovarian cycle with the hormonal cycle, if you have to do a estrogen and a progesterone study, estrogen is less than 50 picograms per deciliter, progesterone is less than 1 nanogram per deciliter. That is the lowest level of hormones in the body, and all the follicles are very quiet. And then what happens whenever the estrogen and progesterone is so low, the endometrium shed, because it's a withdrawal of hormone, and then HPO axis starts pulsatility, and then one of the follicle becomes dominant. If you see on day 5, the follicle which was less than 10 mm on day 2 becomes around 10 to 12 mm. That means selection has started. Day 5 or 6, selection starts happening. Then what happens on day 5? When a follicle gets selected, it starts producing estrogen. It becomes an estrogen microenvironment. So estrogen, which was 50, has become 75 to 100 now. Whenever estrogen becomes little high, this dominant follicle wants to be a queen. It does not want other follicles to follow. So it sends a negative impulse to the brain, HPO axis, that is called as, the negative the negative pathway of the estrogen. What it says to brain is, hey, I'm there here, I don't want other follicles to come, FSH, please come down. Immediately FSH comes down. So the other follicles, if you see on day 7, which were supposed to become dominant follicle, you know, they go for atresia. Only this one becomes, starts growing 1 to 2 mm. See example in other animals like cows, cats, dogs, elephants, this negative inhibition is not there at all. That's the reason they get 6 or 7 follicles, and that's the reason they have multiple pregnancy. And thanks to our uterus, it can bear only 1 or 2 kids. So this negative pathway is so important to cause monofollicular growth of the follicle. Now on day 7, the follicle is already around, it's like around 12 to 14 mm. This too starts working. It starts increasing estrogen itself. Here if you see on day 10, follicle becomes around 14 to 15 mm. Now estrogen, which was 50 on day 2, has become around 200 picograms per deciliter. All the books say, Spiroff, every book says 200 picograms of estrogen sustainedly maintained for 50 hours, the LH surge happens. This is the, one point which triggers the LH surge. So by then it is already 2.5 days. So from 10th to 12th day, the follicle has become 18 mm now, and it is ready to rupture. So once it ruptures, if you see in this video, so the follicles escapes from the primary oocytes escape from the follicle, and there is a Graafian follicle. If you see, just I'll fast track this. This is how I call, to understand easy, a marble in a balloon. The marble has to go outside now. So the follicles come, and the balloon opens up, and the primary oocyte which goes outside the ovary, and it is picked up by the fallopian tube. And then this primary oocyte, if you go in depth, how fast it multiplies. The Graafian follicle which is covering the primary oocyte is washed away by the tubes. That is what we do in IVF. We take the primary oocyte, wash it away. Then there is resumption of meiosis. The metaphase 1 oocyte becomes 2, so immediately it's done, and then there is, if there is a pregnancy happens, that's what happens in the tubes. Now next is about threshold dose. So on day 2, if you see all follicles, you don't see all follicles same size, 4 mm, 5. They are different. One may be 2, one may be 3, or one may be 5, 6, 7. So each follicle has their own threshold and its own size. See, what is threshold? Threshold is very important. If you see the follicle here, they all have receptors. The larger the follicle has more receptors. What is this follicle? This follicle has more FSH receptors. It means it has the lowest threshold. So each follicle has a threshold dose. And then the threshold dose, once it is attained, how is threshold dose attained? In the body, because of the HPO axis, when FSH pulsatile is there, the threshold dose is attained in most of the ladies. But in some ladies, when they don't ovulate, we find the threshold dose for them. We either give letrozole or clomiphene or gonadotropin, depending on so many other factors. So finding the threshold dose for that ovary, for that lady, is the most challenging step in ovulation induction. Our whole responsibility is to find the threshold dose for that follicle. So once the threshold dose is met, say suppose for some women it may be 5 mg letrozole, for some it may be 2.5 mg, for some it may be 7.5. So this is very important to find the threshold dose. Once threshold dose is met, there is rescued by the FSH. And then the selection happens, the follicles start growing, and rest of the follicles go for atresia. So now important concept of this threshold dose is in the window period, very challenging. If the threshold dose is met of 1 follicle, we get monofollicle. If the threshold dose is met for 2 follicles, we get 2 follicles. But it's so important, especially in PCOS, most of the follicles have same threshold dose. They all go together. You give a dose, all the follicles come up. So it's very important to find the threshold dose. Now, individualizing the therapy is the need of the hour. How to find the threshold dose? Each ovary is different, so it depends on the age of the woman, the AFC count, her AMH, and what was the previous response. Whenever we see a woman, please make sure you go back to her history and see previously what was her threshold dose. If you have seen a beautiful follicle, then you already know the threshold dose. It becomes very important for us. And then BMI also plays a major role. Now, what is an ideal protocol for IUI? How I do is, I first see woman whether she's ovulating or she's not ovulating. If she's not at all ovulating, she's having irregular cycles like Shilpa, my idea is to give one follicle, monofollicular. If a woman is already ovulating, that means every month she's releasing one egg already. What am I doing? I try to get, especially in unexplained infertility in endometriosis, I try to get 2 follicles for her to find the threshold dose. So selection, of course, does matter, whatever said and done. See, in IUI especially, best success rate is for a younger woman with an acceptable AFC count. Most of the time tubes are patent, but when we do the scan, we see the tubo-ovarian relation is altered. There is a lot of adhesions. So very important even, scan. And of course, male factor plays a very important role. And then less success in little older women with less AFCs, and though tubes are patent, but still a lot of adhesions are there. I think Dr. Raji will be covering all about IUI optimizing. I'll stick on to ovulation induction itself. So what about when should we do the first scan? Very important. See, 10 years before, when I started my center, I didn't have scan at the very beginning. I was sending all my patients for one of the radiologists to do a scan day 2. They were refusing me. How can you do scan for day 2? They are bleeding. Please don't send her now. Folliculography, you call only on 10th day. I was, no, we are fertility expert. Day 2 is very important for us. So in 10 years, so much has changed about day 2. I think if we take a raise of hand, everybody wants to do day 2 scan, right? Most of the time, I think we have a scan machine with us. We should do a day 2 scan. Basic it is. Why is it so important? If you see on day 2, all the follicles should be quiet. There should be no more than 10 mm. Ideal time to start the ovulation induction. Say suppose in this woman, she has already a follicle which is 14 mm. She has come to you, you have seen her on day 2. What do we do now? Ideally, I would like to postpone the cycle. I will tell her there is some follicle. I don't know whether it's follicle or cyst. But then she says, no, it's very important. My husband has come only for 1 month from out of country. Please induce, do something. Then what should I do is, I should find out whether it's a secretory follicle or not a secretory follicle. How do I know that? We know that on day 2, estrogen is less than 50, progesterone is less than 1. I do these 2 simple tests, call her next day. I tell her, okay, your both hormones are okay. This is a non-secretory cyst. It is not secreting, it's simply sitting there. So then I start my ovulation induction, call her on 10th day. Now on 10th day, I should on day 2 mark this follicle as non-secretory. On 10th day, she comes to me, and if I see this follicle, already follicles are there, then we give HCT trigger later, it won't rupture. This is because non-secretory follicle. On 8th day, I should see another follicle along with this, which is growing up. That is very important point. And then, of course, when it comes to, there are a lot of armamentarium of ovulation induction. If you call who is the best, everybody is good in their own way. Of course, success rate of IUI, if you see compared to oral ovulogen, gonadotropins, you add, definitely it increases success rate. When it's come to ovulation induction, what I would like to announce today is, see, all of us gynecologists, you are the first place where an infertile lady comes to you. So 80% of the women needs ovulation induction. So this still has it plays a major role like a queen. So this ovulation induction is very important. And then clomiphene citrate. Ideally we start with 50 mg, and then on day 7 if there is no dominant follicle, we can increase it to 100 mg. We should not waste time for her. Why is this? There is something called a stair-step protocol. You call her on day 3, give 50 mg, call her on day 7, the threshold dose is not met. There is no dominant follicle. Now you can increase it to 100 mg itself. Why do you want to waste your time? Again, after that, call 7 days later. You see, if there is no dominant follicle, you can make it 150 mg itself. So in this stair-step protocol, what is the difference? It doesn't increase the pregnancy rate. It shortens the time to pregnancy. 3-4 months, you are not wasting your precious months. That's what all the study says. About tamoxifen, I won't talk much because letrozole is already there. So efficacy is similar to clomiphene citrate. What about letrozole? There are lots of ways of using letrozole. The regular standard way. I have a short 5 protocols what I will just explain you. First is the standard protocol where 2.5 mg they say according to the academics. But I usually don't use 2.5 mg. I start with 5 mg. So 5 mg, this is another protocol, 2.5 mg if you give. She comes on 7th day. Please don't tell her you don't have the threshold dose if it's not met, if there is no dominant follicle, don't tell her to come back again. Extend it, give for 5 more days and see. Then third protocol start with 5 mg itself. And then fourth protocol is, in some ladies where threshold dose is not met, you can increase the dose 2.5 second day 5, then 7.5, and then make it 100. And then say suppose in this woman all 4 protocols have failed, there is no dominant follicle at all. Go with the higher dose, 7 point, because in her 7.5 mg would be the threshold dose, because 5 mg also she has not got dominant follicle. So start with 7.5. But not for every woman. First time you see, please don't start with 7.5. When it is failed, then that's the last chance what we have. You can go with 7.5 mg. So then now everything is done. Letrozole I have used, everything. She's still not ovulated. What do we do next? What else is available? Second line therapy is gonadotropin. In gynecologist level, we are little hesitant to start off gonadotropin because of risk of OHSS. So I was thinking, most of the time we always in all seminars we compare clomiphene with letrozole, which is best. But I thought, let us see if they work as friends together, what can happen. So some studies says even before going for gonadotropin, there are 3 case scenarios where you combine them as friends. One case scenario is when a woman is not ovulating with letrozole, combine with clomiphene. Most of the studies says whoever is not ovulating, we have a word called as clomiphene resistance, but we still don't have a word called letrozole resistance. So you can combine, sometime ovulation happens, and then we can go ahead. Then second scenario, when insulin resistance, still clomiphene has a role. Third is unexplained infertility. When you want little 2 follicles in the window period, you can give both the medication. Now gonadotropins, because of the paucity of time, I'll just go ahead fast. When you start gonadotropin, very important is in a window period, don't give very high dose. That is the reason where all the threshold dose of all the follicles are met, you will go with OHSS. If you want to see FSH or HMG, which is better, both Cochrane says both are equal. Whether recombinant or urinary, there's no clinical difference in pregnancy rates. And daily using, once you start FSH, should you continue it daily? Study says if you continue, clinical pregnancy rates are better. Antag I was using before, but it's not improving pregnancy rates. We have stopped, even the study says same. About this one slide, I will just brief you with. Very beautiful normogram. How to start the dose of letrozole. We all know how to say, suppose a woman has come, she is 55 kgs, and she has 10 follicles, 75 is her first dose. Same 55 kgs woman has 20 follicles, then 50 is her starting dose. This is a normogram where you can choose which, thanks to Jatin Shah sir, this is a slide from your own presentation. Thank you so much. Yeah, so step-up protocol. Ideally, if you want to use gonadotropin, start with lower dose, 50 units is ideal, but it's very expensive. If you have to use 50 units, you have to go with a recombinant pen. It becomes very expensive for our country. Most of the Western people where they have a recombinant pen, they use this protocol. In our country, we use standard step-up protocol using 75 gonadotropins and then call them on 7th day. If there is one dominant follicle, it means threshold dose is met. If there is no dominant follicle, we have to increase the dose to 150 and call her again to see whether the threshold dose is met. So everything depends upon the threshold dose of the follicle. And then now chronic low dose, they say for PCOS, you give a very low dose for longer time, 80% of the women will ovulate, and even clinical pregnancy rates are good in these ladies. So then there is all step down. I won't go into depth because we don't use it now. It causes a lot of OHSS and multiple pregnancy risks. There are many protocols if you have to say. But in our Shilpa, what happened was, she was PCOS lady. For her, what we did was, we started with the letrozole and then continued HMG, she conceived. But if it is a unexplained infertility, I always start with gonadotropin in the window period, so that if I put gonadotropin on day 3 and day 5, I may get 2 follicles. So this is, and then every time we concentrate on the follicles. What about endometrium? Most of the time follicle is 18 mm, endometrium is still 5 or 6 mm. So how do we do? If you delay 1 or 2 days, make the follicle 20 mm, endometrium may catch up. That is the first way. Second is, you should know whether a follicle is culprit or endometrium is culprit. Say suppose follicle is 18 mm, endometrium is 6 mm. I do a test, again estrogen. Estrogen, if it is 250, that means the follicle is mature, it's releasing hormones. But endometrium is the culprit. Even with 250 estrogen, endometrium should have been 7 mm. It is not working well. Then I subject them for hysteroscopy. That means to say there is something issue in the endometrium. If the estrogen level is 100 or less, then I know follicle is the problem. It's not releasing estrogen. So I give more time for endometrium. Now, this is one typical example. This was some 3 years back. I got this prescription. They have started letrozole. They have started with 5 mg 3rd, 4th, 5th, 6th, 7th day. Without doing follicular study, they have started progynoa, estrogen also. So what wrong it is here? All threshold dose is not met. You are already suppressing. See, once in letrozole you are giving and causing anti-estrogenic effect, FSH start pulsatile. By the time it is getting selected follicle, you are dumping estrogen. So follicle get confused. So very, very important, wrong usage of estrogen can even hamper the normal folliculogenesis. So in hypo, we have to use HMG preferably. So conclusion slide is gonadotrophins definitely gives increased pregnancy rates in IUI. So when to use gonadotrophin, only thing we should remember is window period. We should not overshoot the dose. And that is the only time when all the follicles get selected. So thank you everybody. So they say spirit of physician is to be a permanent student of science because the absolute truth of today is the relative truth of tomorrow. Thank you so much.
IUI, ovulation induction and folliculometry, it was very crystal clear, given us very practical points, and your slides are also excellent. It was an excellent presentation. Thank you so much. Any doubts?
Hi ma'am, I have 3 doubts. One is whether the cyst on day 2 is functional, non-functional. Can we see the endometrial thickness and decide it, or it is needed to do only estrogen?
On day 2?
Day 2.
Okay, very valid doubt. Day 2, usually endometrium should shed. It should become less than 3 mm. It's a very valid point. But in say suppose PCOS, what happens? 3 months she doesn't menstruate at all. So endometrium is so thick, these people will have cystoglandular hyperplasia along with Steen-Levitard syndrome, we used to call it before. Big ovary with irregular cycle, thick endometrium. So in most of these PCOS, what happens on day 2 also endometrium is 7 or 8 mm. It doesn't shed properly. So as a marker, according to any studies, endometrium can't be taken totally to find out whether it is totally in the, it is in the resting phase.
Okay.
So combined together, as a clinician, the more scan we do, we know, okay, the follicles are all quiet, endometrium is quiet, so I don't want to do hormone test. Yeah. Ideally, I don't believe in doing too many tests. But in certain situations, when we need to know what the diagnosis is, these come to play.
And one more doubt. These gonadotropin injections, do you give daily or alternate days in any protocol?
I will be very honest here. I don't give daily because cost also plays a major role. If you weigh and balance, giving daily, I started for few patients long time back, but the expenditure what they have and they don't become pregnant, it's like IVF money and they don't become pregnant. We know for ovulation induction, so I ideally don't give daily.
If you give 1 or 2 injections also, they are ovulating.
What I do is ideally I start with oral ovulogens because it sensitizes the gonadotrophins. The dose becomes, the requirement dose becomes very less. So I combine most of the time with letrozole, and then once the follicle is dominant, then I add the gonadotrophins.
One more doubt, ma'am. Does progynoa has no role, madam?
No, not exactly no role. I'll come to it. Progynoa means estrogen basically. So estrogen has a role. It's like a weapon. You should be very strong in your academics. If you see a dominant follicle, already selected follicle, only endometrium is a problem. Again, when it go to academics, it becomes very debatable. Most of the study doesn't support estrogen. But if you know this follicle is dominant, it's doing very well, ideally the endometrium should catch up. Estrogen in the follicle would have been 250, endometrium should have come. There is some issue. So ideally, it's better to avoid estrogen. But, so many times it happens that, okay, 1 or 2 days we will give. But again, it's always a debatable topic.